Bone, muscle, and connective tissue adaptations to physical activity. The three major components of muscular skeletal system are bone, skeletal muscle, and intervening connective tissue. Each component contributes to the overall function of the entire system. Bone provides the structural support for the system. Muscle contains the contractile units and converts stored energy into mechanical energy needed to produce movement, and connective tissue acts as the framework through the forces generated by the contracting musculature can be transmitted to the associated bony levers to elicit the desired movement. The three components are functionally inseparable in their role in athletic performance. Muscles cannot undergo even an isometric contraction without using bone and connective tissue for stabilization. The ability to create, transmit, and sustain forces required to successfully create movement depends on a predetermined balance of functional abilities among bone, muscle, and connective tissue. This intimate relationship suggests that when the system is stressed, as during physical activity, bone, muscle, and connective tissue must adapt in a coordinated manner to preserve the strength and integrity of the whole force-generating system. When an athlete repeatedly stresses the musculoskeletal system beyond its normal level of functioning, it is not uncommon for bone or connective tissue adaptations to lag behind the development of the exercising muscle. This phenomenon needs to be recognized by the strength and conditioning professional so that injury is avoided and athletic performance maximized. Understanding how the individual components of the musculoskeletal system adapt to physical activity provides a knowledge base from which the strength and conditioning professional can predict the outcome of a specific training program. This chapter describes the adaptations that occur in bone, muscle, and connective tissue in the response to various exercise programs. Background information regarding the essential structural features of the bone and other connective tissue is included in this chapter to assist the reader in understanding the specific adaptations that occur within these tissues. The structure of a skeletal muscle system is described in detail in Chapter 1 and thus is not presented here. Adaptations of bone to exercise. Bone is classified as a connective tissue. It is unique connective tissue in that it becomes mineralized and thereby provides a rigid support structure. Interestingly, this rigid structure is actually a very active tissue that is sensitive to changes in forces it experiences and has the capacity for growth and regeneration if damaged. Exercise creates mechanical forces that cause deformation of specific regions of the skeleton. These forces can be bending forces, compression forces, torsional forces, or the forces created by muscular contraction on the tendinous insertion of a muscle onto bone. The section that follows discusses bone structure and formation, the types of forces that best stimulate new bone formation, how bone responds to mechanical forces, and the response of bone to physical activity. The biology of bone formation. In response to mechanical loading, bone cells called osteoblasts migrate to the bone surface that is experiencing the strain and begin producing the process of bone modeling. The osteoblasts manufacture and secrete proteins, primarily collagen molecules, that is deposited in the space between the bone cells to increase the strength of the bone in that area. These proteins form a meshwork called the bone matrix. Between the bone cells, these proteins added to the matrix eventually become mineralized as calcium phosphate crystals. Hydroxyapatite. Precipitate from this extracellular fluid and bind to the protein matrix. It is the mineralization of the matrix that gives bone its characteristic rigidity. New bone formation occurs predominantly on the outer surface of the bone called the periosteum. Laying down new bone on the periphery to increase bone diameter is the most effective way of increasing bone strength without compromising the space required for the highly vasculature bone marrow cavity at the center of the bone. Growth of bone in this manner is somewhat analogous to the growth of skeletal muscle in response to exercise. During the process of bone hypertrophy, new myofilaments are added to the periphery of the existing myofibril. The myofilaments are layered onto the outside of the existing myofibril rather than within the myofibril to avoid altering the geometric arrangement of the myofilaments within the existing sarcomeres of the myofibril. The adaptation of bone to mechanical loading occurs at different rates in the axial skeleton and the appendicular skeleton, owing to the different amounts of trabecular, spongy, bone and cortical, compact, bone. The axial skeleton consists of the skull, cranium, vertebrae column, C1 through coccyx, ribs, and sternum. The appendicular skeleton includes the shoulder girdle, scapula, clavicle, humerus, pelvis, and long bones of the upper and lower extremities. Cortical bone is dense and forms a compact outer cell that is bridged by interconnecting narrow and delicate plates of trabecular bone. The spaces between the trabecular bone plates and the occupied by bone marrow that consists of adipose tissue and blood products. Blood vessels from the marrow cavity extend into the bone cortical through the network of vertical and horizontal canals. Trabecular bone is able to respond more rapidly to stimuli than cortical bone. The bones of the vertebral column contain approximately 70% trabecular bone by volume, whereas trabecular bone is found only in the marrow of the cavities and the ends of the long bones. Deposition of new collagen fibers in vertebral bone can be expected after 8 to 12 weeks of mechanical loading. Subsequently, mineralization of new bone matrix gives full strength to the new bone, requires additional time, and may take several weeks to months to complete. Stimulus for new bone formation. The term minimal essential strain, MES, refers to the threshold stimulus that initiates new bone formation. A force that reaches or exceeds this threshold and is repeated often enough will signal osteoblasts to migrate to that region of the bone and lay down matrix proteins, collagen. To increase the strength of bone in that area, forces that fall below the MES do not present a stimulus for new bone formation. Physical activities that generate forces exceeding those MES activities represent an increase in intensity relative to the normal daily activities. For example, in aged sedentary individuals, brisk walking may exceed the MES, while in younger, more active people, the activities needed to be higher intensity, such as sprinting, jumping, and heavy resistance exercise to exceed MES. Regardless of the population and their loading history, it is clear that the activities chosen need to be weight-bearing, that is, having the additional stress of one's body weight involved to provide the most effective stimulus for bone formation. Bone cells regulate the quantity of the bone in each area, ensuring that forces are experienced on a regular basis do not exceed the MES. The regulation of bone mass establishes a margin of safety in the bone against the fracture. The strain registered by the bone is function of the force per unit area of the bone. The MES is thought to be a level of strain at approximately 1/10 of the force required to fracture the bone. If a large force is regularly applied to the bone area of the bone, supporting the load needs to be large enough to dissipate the forces preventing damage and consequent to the loading. Increasing the diameter of the bone by laying down new bone as a periosteum allows the forces to be distributed over larger surfaces. Thus, there is a decrease in the amount of forces per unit area across the bone surface. After bone growth occurs, the same forces previously exceeded the MES will now be below the MES threshold and will not present a new threat to the bone. Effects of physical activity and immobility on bone. The total mass of the muscle reflects the force that the muscle is capable of exerting on the bone to which it is attached. The forces capable of larger and better trained muscles are greater. Consequently, the related regions of connective tissue to the bone must increase their mass and strength to provide the sufficient support structure for the hypertrophied muscles. To generalize, an increase in or decrease in the muscle strength or mass through the strain or periods of reduced activity results in the corresponding increase or decrease of connective tissue and bone. The loss of the bone matrix and bone mineral density, the quantity of mineral deposited on a given area of bone, following a period of reduced loading or immobility, appears to occur at a much more rapid rate than the formation and mineralization of new bone. Rapid removal of calcium from the bone, which results in a net loss of bone mineral content, occurs only after a few weeks of bed rest. Interestingly, the absence of weight-bearing forces on the spine during bed rest have a greater influence on the vertebral bone loss than the absence of muscular contractions. Preservation of bone mineral content in the spine during the period of bed rest can be achieved with 3 hours of quiet standing per day. This formation underlines the importance of loading the spine with weight-bearing compressive forces during the exercise program designed to increase bone mass. Important training concepts for stimulating new bone formation. Numerous studies have demonstrated the significant positive correlation between bone mineral density and the strength and mass of the attached musculature. Recently, it has been noted that certain populations of physical activity seems to be influenced bone mass area with more bone density. Activities that stimulate muscle hypertrophy and strength gains also appear to stimulate the growth of bone and associated connective tissue. It is currently thought that training programs designed to stimulate bone growth need to incorporate specific of loading, proper exercise selection, progressive overload, and variation. Specificity of loading. Specificity of loading means employing exercises that directly load a particular region of the skeleton. The forces created by exercise are directly through the supporting skeletal structure. If the body interprets these forces as new or unusual, they will stimulate bone growth in the area receiving the strain. As a simple yet practical example, running may be a good stimulus for increasing bone mineral density in the femur. But the wrong choice for loading the wrist. More appropriate exercises for stimulating bone growth of the wrist might include bench presses, overhead presses. The concept of specificity of loading becomes particularly important when strength and conditioning professionals prescribe exercises to increase bone mass in the regions of the skeleton most commonly affected by osteoporosis. Osteoporosis is a disease in which bone mineral density and bone mass becomes reduced to critically low levels. When the bone becomes this compromised, forces that would normally be absorbed by the skeleton are now result in fractures. The sites of fracture that are most devastating are the spine and the hip. To minimize the risk of developing critically low levels of bone mineral density in late adulthood, current thinking suggests that individuals maximize their peak bone mineral density in early adulthood, when they are most capable of performing the intense physical activities that increase bone mineral density. Recent studies indicate that high-impact loading exercises for the lower body, such as gymnastics, volleyball, and basketball, selectively increase bone mineral density at critically relevant sites such as the hip, spine, and more lower-impact activities do. Additionally, increasing bone mineral density may be realized even in high-trained college athletes with already high initial levels of bone mineral density. These changes in bone mineral density are independent and reproductive hormonal status if the stimulus is sufficient magnitude. The skeleton of the appropriate exercise, the selection of the appropriate exercise to elicit maximal osteogenic stimuli, factors that stimulate new bone formation at a specific skeletal site, has been a common source of error in exercise literature. The choice of exercises should be based on those exercises that involve many muscle groups in one exercise. Direct the force vectors through the spine and the hip and allow greater absolute loads to be used in training structural exercises. Use of body part or isolation exercises should be limited because they isolate a single muscle group by bracing and stabilizing the rest of the body, which equipment supports rather than using the body's synergistic muscle groups to support during the movement. For example, performing knee extension rather than a back squat eliminates the compressive forces of the bar on the person's back and the muscular contraction of the synergistic muscle groups acting on the vertebral column for stabilization during the exercise. The only forces experienced by the lower limbs during the knee extension exercise are those the point of muscle attachment in the knee extensions and the longitudinally directed compressive bending forces experienced through the lower limb. As one supports the load during the back squat are missing. Thus, structural exercises such as squats, cleans, deadlifts, snatches, and jerks for the axial skeleton and hip and bench presses, overhead presses for the upper limbs are recommended for the increasing the muscle and bone strength. Progressive overload. Because the bone and connective tissue respond to the mechanical forces that threaten to the supporting structure of the contractile musculature, the principle of the progressive overload, progressively placing greater than normal demands on the exercising musculature, applies to training to increase the bone mass as well as training to improve muscle strength. Although the maximal strength of bone and connective tissue is maximized well above the voluntary force capabilities of associated musculature, those tissues respond to dramatic or unusual forces that are repetitive presented to the skeleton. The adaptive response is to ensure that the forces do not exceed a specific critical level that would place the bone or the connective tissue at risk for damage. Stress factors. Microfractures in bone due to structural fatigue and soft tissue injuries can occur when the force is routinely applied to the bone and related connective tissue before they have had a chance to adapt to the new exercise stimulus. This occurs, for example, when previously sedentary recruits undergo rigorous physical training following arrival at a military training center. The training often includes running with a weighted backpack. The dynamic change in the intensity and quantity of daily physical activity necessitates rapid adaptation of bone and connective tissue. Recruits either make the adaptation very quickly or sustain daily musculoskeletal damage that it becomes cumulative when they cannot be repaired quickly enough. The end result of such damage can include stress fractures, tendinitis, and muscle injuries, all of which can be quite painful and take weeks or months to heal. Appropriate application of the principles of overloading the musculoskeletal system and progressively increasing the load as the tissues become accustomed to the stimulus are the keys to increasing bone and connective tissue strength. Support for this concept comes from the studies that have compared the bone mineral density of various groups of athletes with the mass and strength of the associated musculature and with the bone mineral content of non-athletes. In fact, elite adolescent weightlifters have been found to possess levels of bone mineralization that far exceed the typical values found in untrained adults with fully mature bones. This observation is interesting because it indicates that young bone may be more responsive to osteogenic stimulus than mature bone. The enhanced sensitivity of young bone as mechanical forces have also been found in other human studies and various investigations involving experimental animals. Evidence suggests that physical activity during growth modulates the external geometry of the trabecular architecture of bone, potentially enhancing skeletal strength. The result of these studies have led to the hypothesis that in order to avoid dangerous low bone mass in old age, people should train to maximally elevate their peak bone mass, the maximum bone mass achieved during early adulthood when the mechanisms for bone growth still function at optimal levels. Training variation. Another important consideration when designing programs to stimulate the new bone formation is variation in exercise selection. The internal architecture of the human skeleton has a mechanism in place through which it compensates for new strain patterns experienced by the bone. To optimally dissipate the imposed forces, the direction of the collagen fibers with the bone matrix may change to conform to the lines of the stress experienced by the bone. Thus, changing the distribution of force vectors by using a variety of exercises continually present a unique stimulus for the new bone formation within a given region of bone. The essential compounds of mechanical loading. The components of mechanical load that stimulate bone growth are magnitude of the load, intensity, rate, speed of loading, direction of the forces, and volume of loading, number of repetitions. The first three components have been shown to exert a powerful influence on new bone formation in the following manner. The greater the magnitude of the load, the greater the stimulus for bone growth. Higher rates of contraction, higher output activities enhance the stimulus for new bone growth. An alteration of the normal patterns of bone loading, direction of the force, with other variables held constant stimulates bone growth. If the magnitude of the load and the rate of the force application or both are sufficient, then there is typically not a need to perform more than a total of 30 to 35 repetitions, as a greater volume of loading is not likely to provide any additional stimulus for bone growth. Mechanical loading from resistance exercise. Few longitudinal training studies have been performed that use resistance training as a stimulus for new bone growth. These studies have reported variable results, with some studies showing gains in bone mineral density and others showing little or no change consequent to training. To date, longitudinal training studies have included resistance exercise, have not duplicated the relative magnitude of loading rate or load of loading. The type of exercise is typically used by competitive strength athletes. Therefore, the magnitude of the response of bone to heavy resistance exercises remains unclear. Mechanical loading from aerobic exercise. The selection of different forms of aerobic exercise have met with some success in bringing about improvements in bone mass. The aerobic training programs that there are most successful to stimulate bone growth improve more intense physical activities such as rowing, stair climbing, running, and running with weighted packs or vests. The key to the success of aerobic exercise programs in stimulating new bone formation is that the aerobic activity be significantly more intense than the normal daily activities typically experienced by the person. Thus, brisk walking may stimulate bone growth in previously sedentary individuals who are not accustomed to that level of activity. The intensity of the activity must systematically increase to continually overload the bone. Eventually, it may become difficult to overload the bone through aerobic exercise when the person's oxygen transport system, rather than the limitations of the musculoskeletal system, restrict the progression to a new exercise intensity. Bone responds to the magnitude and rate of external loading. Therefore, to enhance the stimulus to the musculoskeletal system, it is necessary to increase the rate of limb movement. Using interval training techniques in one method of providing a greater osteogenic stimulus while still providing the benefits associated with regular aerobic exercise. Mechanical loading for athletes. In training for improvements in muscle strength and size, athletes should incorporate into their training programs all the components of mechanical loading necessary to stimulate new bone formation. A study of exercise and variables common in the training programs of athletic populations found that to have a high bone mineral density, values shown in Table 4.1. The table is intended to be a guideline for designing resistance exercises programs to promote increase in bone mass. Until further studies are performed, the guidelines described in Table 4.1 must be viewed as preliminary because they arise from the observation of strong correlated between muscle strength and bone mineral density, rather than the documented cause and effect relationship. Mechanical loading for untrained or aged people. In designing exercise programs to increase bone strength in untrained or aged people, the strength and conditioning professional must use the same precautionary guidelines that apply to prescribing resistance exercise for the population. A proper patient history, physical exam, and an analysis of joint stability, flexibility, and muscular strength. The exercise prescription should be based in the measured physical capabilities of the individual and his or her general state of health, vision, balance, and nutritional status. For proper exercise techniques should be taught to ensure that the individual can safely and effectively perform the selective exercise before the loading is introduced. Body part exercises may be used for gently introducing untrained people to the resistance exercise. Increased kinesthetic awareness and initial muscle conditioning should be priority goals at the beginning of new conditioning programs for previously untrained people. Progression to structural exercise will require proper instruction in the practice to establish the necessary conditioning and to develop the baseline level of strength needed to safely and effectively execute the more complex structural movements. Loading should begin low enough to permit perfect execution of the exercise and bring about gentle muscle fatigue. Advances in load and quantity of exercise performed should be in accordance with the individual's gains in strength and muscular endurance.